This is all the shit that you were not taught in medical school. I see very few people, maybe 1 in 50 with optimal baseline thyroid function, and past the age of 50, I would say 1 in 100. For the last few years, I've gotten up and given speeches more about the philosophy of masculine, of what we are looking to achieve from a holistic, without the woo-woo esoteric crap, but generally, actually holistic outcomes. Today, I'm gonna do something a little bit different. I'm going to give a deep dive on some advanced clinical stuff. I have a lot of lectures online where I talk about the nitty-gritty of TRT dosing and protocols. Today, I wanna go a little bit deeper on a few points, which I think are a little bit more nuanced, a little bit more interesting, but I am aware that the room is very spread today. So while this speech is going to be more geared towards the practitioners and providers in the room, I have been able to work in a few general points that are going to be applicable to every single person here, regardless of why you are here today. So if you feel like something's going a little bit over your head, maybe if something's not too understandable, don't worry, the latter points are more generalized. So this is all the shit that you were not taught in medical school. If you pay attention and listen to me today, these are the things that I'm going to be teaching you. We are going to go through augmenting Cabergoline with T3 for Prolactinomas. I am going to be explaining to you the how and the why of executing TRT injections daily. I'm also going to be talking about testosterone cream for metabolic syndrome and liver disease. I'm going to be talking about sublingual melatonin combined with oral micronized melatonin. We are going to go through a high-performance sleep stack, not just for sleep onset, but sleep maintenance in terms of staying asleep. I'm going to answer the question, should everyone be taking at least a little bit of thyroid? I'm also going to be talking about PM dosing of thyroid for patients with hypothyroidism. And finally, I'm going to wrap on treating alcoholic fatty liver disease and non-alcoholic fatty liver disease. First point here today we're talking about is augmenting Cabergoline with T3. So for the people who aren't aware, Cabergoline is a dopamine agonist drug. It is, and if it is not in any country, it should be the frontline treatment for prolactinomas, as if it is used properly and effectively, it will actually cause the tumor to shrink and to vanish. This is a much better alternative than having brain surgery. Now, Cabergoline is typically prescribed at a 0.25 to 0.5 milligram dose twice a week. Now, this, like many things in medicine, is not geared towards what delivers the optimal outcome. It is delivered for patient compliance. It is easier to get someone to take something twice a week than it is to get them to take it every day. But Cabergoline does have a long half-life. It has a very long half-life, but there is a difference between the half-life and the pharmacokinetic peak. Now, what pharmacokinetics means, which is what I'm going to be talking a bit about today, is the direction in which the drug moves over the half-life. So if we're looking for this twice-weekly dosing, yes, there is effective suppression of prolactin over the 7-day period. Although it peaks early on day 1, it does still cause a prolonged prolactin suppression. So this protocol is not redundant, it is not broken, it is not ineffective, it does work. But there are better ways to use it because of how it peaks and how it has this activity at the dopamine D2 receptor. So the way that I prefer to mentor my clients, as well as the doctors and practitioners that I work with, is daily dosing of Cabergoline. Typically, we are looking at a 0.5 milligram tablet of Dostonex, which is the commercial brand, and this can be cut into quarters. I have found, working with dozens of patients and clients who have prolactinomas, which are these prolactin-secreting tumors, that a 0.125 milligram dose daily is more effective than a 1/4 to 1/2 milligram twice a week, produces less side effects, and is arguably going to be more safe and beneficial in terms of the potential for negative outcomes that may come from using the drug. Next slide, please. So, the main point that I want to talk here about is this idea of adding T3, or people can use NDT as well, to the Cabergoline therapy. The reason for this is that the prolactin secreting tumor, the prolactinoma, is not the only mechanism in which the body can be overproducing prolactin. When we're using pharmaceuticals, the goal should always be to use the minimal effective dose. And one of the main feedback mechanisms that the body has for prolactin release is actually the T3 activating the thyroid receptor. So even for patients who are not necessarily hypothyroid, by adding 5 to 10 micrograms of T3 twice a day, or potentially even 15 to 30 milligrams of NDT, which converts to a quarter grain to half a grain of NDT, this can actually help to not only support secondary prolactin suppression, but can also help their mood, their well-being, their energy levels, and their performance, which is overall going to lead to a much better subjective outcome for their treatment. So I'm going to move on to daily TRT injections now. And I am a big advocate of injecting testosterone daily. I have been for a long time, but in the recent years, I've become more in favor of pushing this as a frontline treatment protocol. Now, the thing that I've said for a long time, I said this in my ebook, TRT 101, that I wrote a few years ago. If anyone would like a copy, please come up to me after the speech today, and I'll be happy to give you a free copy. All patients should administer TRT as often as they will. TRT should be injected as often as possible. Now, when we're looking at hormone therapy, one of the main factors that drives not only the beneficial outcome, but also reducing the potential side effects is stable hormone levels. Now, a lot of the time we look at the half-life. We look at the half-life of cypionate and enanthate. People say it's 7 days, 10 days, it's 4.5 days. But I'd like to give an example. If you wanted to be evenly caffeinated, you wanted to have an even amount of the effects of caffeine in your body, would you have a second cup of coffee at the 8-hour half-life? No, of course not. We know that coffee does not release a steady amount of stimulation that rises gradually for 4 hours and then drops off gradually for another 4 hours. There is a pronounced peak at about 30 to 90 minutes, despite the fact that the coffee or the caffeine has a half-life of 8 hours. This is because a drug does not peak evenly in the middle of the half-life. There is a more pronounced peak at the start. Testosterone cypionate peaks at 24 to 36 hours. Therefore, if it is injected twice a week, 3 times a week, every other day, it maintains what's called stable levels in the body, or what's referred to as a steady state, but this does not mean that the level is actually steady. Steady state means that it stays within a therapeutic ceiling and a floor, but it moves within this therapeutic ceiling and floor quite dramatically. And if we can stabilize the levels, we are going to have much fewer side effects. I used to sell mobile phones when I was at university. I used to work at a phone shop. Back in the day when you used to be able to actually take the battery out of the phone, showing my age. But when we're looking at a case of a patient or a client who's having side effects on TRT, I liken this to when someone came in with their phone and I said, have you tried turning it off and turning it back on again? And that would generally fix most of the issues unless they, dropped it in the toilet or took it for a swim in the ocean. TRT is the same. One of the easiest frontline ways to resolve side effects is increasing injection frequency. And if every single client and patient started on daily injections, people would receive much fewer troubleshooting emails, phone calls, and problems and follow-ups because the levels are stable. Now, the biggest challenge with daily injections is compliance. How do I get someone to actually stick a needle into their deltoid every single day? It's using a smaller needle. Typically, we use 27-gauge insulin syringes. And I can say from personal experience, as well as experience working with thousands of clients all over the world for the last 6 years, there is orders of magnitude difference in comfort between a 27-gauge and a 29-gauge insulin syringe. As the number goes up, the needle gets thinner. The thinner the needle, the less it hurts when you stick it into your shoulder. Now, 27-gauge needles daily is a pretty tough ask, but a 29-gauge needle daily is very doable. And when we're injecting a lot less volume of oil, this becomes much easier to do. So, the thing that I put to a lot of my guys, when they say, oh, I couldn't do daily injections, I say, well, diabetic little girls do it every day just to stay alive. So if you can't do it daily to optimize your male androgen levels, maybe you don't deserve to have side effect-free treatment. The way that I also pose it to them is I say, if you are not willing to do the thing that you're already doing 3 times a week every day to resolve the side effects you're having, the side effects can't really be that bad. It's not that much of a bigger ask. And I like to give people a defined period. I say, look, do it for 8 weeks and see how you go. And they go, okay, I can wrap my head around that. It's kind of like if you want someone to quit drinking alcohol. You say, look, just 30 days, see how you go with it. If you give someone a defined end date, it makes it much easier to wrap their head around. And then when the side effects resolve, they go, hey, this is actually worth it. I can keep doing this. So this should be the frontline intervention for troubleshooting. And there is no benefit, regardless of the SHBG level, regardless of whatever argument someone on Reddit or YouTube wants to make, for less frequent injections than daily, other than simply convenience. So, daily injection protocols should be titrated by 4 milligrams for a 200 milligram per mil concentration, which is the standard here, or 5 milligrams per injection if it's a 250 milligram per mil solution, which is the standard in Europe, UK, and Australia. This is because this is one little 0.02 mil dash on the insulin syringe that you can actually measure. And this is very simple. You can titrate the daily dose up or down by the minimal amount that you can measure on the syringe until lab work becomes optimal, side effects resolve, and everything is working the way it should. It actually makes the whole process much simpler. So the other benefit of daily injections is that because the levels are stable, it actually allows the patient to tolerate and benefit from higher levels of testosterone while requiring less total milligrams per week to achieve this level. It is more efficient and it is more effective. And if we can combine those two things for optimizing a protocol, that is the definition of an improvement. If you've just started TRT, it is completely normal to feel overwhelmed and confused. There's a lot of new territory to cover, and there is a lot of conflicting information. I wrote TRT 101 so that you can have everything that you need to know in an instruction manual in one place that you can refer back to, that you can have all the questions answered before they even come up. TRT 101 is my best practice approach for TRT from start to finish, and it contains everything that you need to avoid all the challenges and pitfalls that I've seen come up in my clients over the last 5 years. You can check it out via the link below. So, I'm going to transition into talking about cream. And testosterone cream sometimes gets a little bit of a bad rap because the commercial products, Andro Forte 2, Andro Forte 5, or if we're going to talk about gels, we've got Testo gels. These products are basically garbage. They have very low bioavailability. Some people do well on them. These are called outliers, and exceptions do not disprove rules. So if we're looking at a testosterone cream in a 20% HRT base, this is what allows the side effect factories to actually have an optimal treatment outcome. We all know from everyone working in this field, if you have someone come in who's obese, morbidly obese, they need TRT, maybe they're drinking too much alcohol, maybe they've got some liver issues from drinking too much alcohol for too long, this is going to cause them to have side effects. And a lot of the time, a practitioner will try to find this median sweet spot between enough testosterone that resolves the symptoms of hypogonadism, but not so much testosterone that it tips up into causing an issue. The problem is, they will not tolerate the amount of testosterone in an injectable that they need until the metabolic syndrome has resolved. In a perfect world, every single TRT patient would be fit, jacked, and healthy. But the problem is, when someone has been hypogonadal for a long period of time, they typically are overweight. They typically are insulin resistant, especially in the US because of the food over here. And this creates a big problem for the patient having side effects and the practitioner not having a happy patient. So, I'll take you back on that slide. So, the thing that I always find funny, and this always gives me a laugh, is that when someone comes back to see me after 3 to 6 months of being on cream, and I ask, how is everything going? And these are people who would be massively disposed to having all kinds of side effects, gyno, being overly emotional, water retention, things like this, sweating too much, acne. They say, it's really inconvenient to shave my balls to apply the cream. And I go, is that the only problem? And they're like, yeah. And I'm like, that is a miracle. That is something we should be celebrating. And the reason why this is able to occur is that when you apply testosterone to the scrotal skin, the testosterone is going directly into the bloodstream with more exposure to the 5-alpha reductase enzyme, leading to a very different ratio of testosterone to DHT to estradiol than an obese patient or someone who is insulin resistant would typically have. So, if we are in a situation where we are allowing a patient to have these improved androgen to estrogen to testosterone ratios without having to use ancillary medications, what we are doing, and this is the key point, is that we are able to allow the patient to have the same outcomes hormonally when they are obese as someone who would be fit, lean, jacked, and healthy when using testosterone. This leads to better symptom resolution, better subjective well-being, and less side effects. What this means is that every single practitioner who is wanting to work with patients to deliver the best outcome possible needs to have cream in their toolbox. Next one. So, the problem is that many patients will push for injections. They'll say, well, I was on Reddit and I was on YouTube and I was in this Facebook group and they said that creams are shit, they don't work, I want injections. And this happens all the time. The important thing for practitioners to know and to understand is that sick people don't know what they need. And what they want typically is the problem of why they were sick in the first place. It is up to the practitioner, and this is the key point that I see so many people fail at, is that practitioners need to be steadfast in their recommendations in advocating for the best interest of the patient. You need to be comfortable saying no. So testosterone cream comes in 4 bioavailable bases. We've got the HRT base, we've got the liposomal base, we've got the Atretus base, and we've got the Versa base. All of these bases work. And it's kind of splitting hairs in terms of which one is better, but the HRT base is superior. It has better absorption. It absorbs faster, meaning that it's more convenient to use. It is a more natural product, and it doesn't leave a powdery residue or a chemically smell on the scrotum, which is not ideal. So one thing that I often say to my clients is I say, look, we're going to start with cream, and if you really want to transition to injections, we can once you lose some weight. Once you get to the point that we actually resolve the insulin resistance on the blood work, fasting insulin, HbA1c, then we may be able to tolerate injections. And if that's what you want to do, we can absolutely do it at that point. So if we are dealing with patients or clients who are unable to access testosterone cream, depending on where they live, maybe the practitioner doesn't have a pharmacy who makes it, or they're living in a country that doesn't even offer it, there are alternatives. And this is where I basically will mandate daily injections. And I also like to augment this treatment with metformin and injectable glutathione as an alternative. T3 can also be beneficial for reasons I'm going to discuss shortly. And using this treatment approach in synergy, 500 milligrams of XR metformin twice daily, 50 milligrams of injectable glutathione daily subcutaneous, and 5 to 10 micrograms of T3 twice a day can be very effective in restoring metabolic function that is driving the shit that everyone is using aromatase inhibitors to try to solve. This is addressing the upstream metabolic and inflammatory issue that is causing the downstream negative symptoms that don't resolve when you add anastrozole. The part that people don't seem to get is that when someone is a metabolic dumpster fire, they don't just have increased expression of aromatase, they have suppression of 5-alpha reductase. This is the problem. And when we use a transscrotal cream and we allow for increased exposure to the enzyme which is reduced systemically, we are able to achieve a healthy optimal ratio of androgens to estrogens, which leads to better outcomes. So I'm going to segue into melatonin now, and for people who've seen me speak on melatonin before, I recently did a podcast tour through the United States, and I joked that people asked me more about melatonin than they asked me about testosterone. So melatonin is something that is a fascinating molecule, and if people want to learn more about high-dose melatonin, I strongly recommend checking out the book, The Miracle Molecule by Dr. John Lawrence. And this is something that inspired me a lot, not only in education, but in practice around utilizing high doses of melatonin. They have done studies where they tried to kill rats or cause problems with high-dose melatonin, and it's very funny when you read the study because the researchers were giving them the equivalent of grams and grams and grams of melatonin, and they basically said, we have to abandon this study. The rats are just getting healthier. It's not causing any problems. We can't do any damage with this stuff. So micronized melatonin is the key. I know that probably everyone in this room, either themselves or knows someone that they've worked with or a friend or a family member who've tried melatonin that they've bought from NAFLD, Life Extension, they've bought it from Whole Foods or Amazon or whatever. If it is not micronized, the bioavailability is so poor that it is not doing much of anything. The half-life is very short, and the first-pass metabolism in the liver renders it relatively ineffective. When you micronize a hormone, you make it so tiny that it basically slips through the liver, kind of like incognito mode, and it gets into the gastrointestinal tract, and it absorbs very gradually with much higher bioavailability. If it's not micronized, and most compounded preparations are micronized by default, but it is important to specify this on the prescription, it is not worth using. It can also be bound to a sustained release matrix, which will further increase what's called the area under the curve. The body can only absorb so much melatonin at once. So if we have a method to increase bioavailability and increase the amount of time that the receptors are exposed to the hormone, we can net much more of the antioxidant effects. Melatonin is kind of effective for sleep maintenance, but it may be pretty ineffective for sleep onset. And a lot of the time, people are looking for something to help them relax, unwind, switch their mind off, and get to sleep. This is where sublingual melatonin comes into play. 5 to 20 milligrams of sublingual melatonin not only allows for this rapid absorption to create a relaxing, cortisol antagonistic sedative effect, but it also has the higher bioavailability that you get from micronized preparations because it is absorbing straight into the mucous membrane in the gums. So sublingual melatonin is much more effective for sleep onset, but because it's in and out of the system extremely rapidly, it is not going to be very useful for the antioxidant benefits, which is where melatonin really shines. So if we are in a situation where we're wanting to get the best of both worlds, we get the best of both worlds. We combine them, we use both. There is no reason that sublingual melatonin and oral micronized melatonin have to be mutually exclusive. You use them together. And many patients will experience improved sleep metrics with things like an Aura or a Whoop or a Garmin, as well as improved well-being, especially if they have sleep disturbances due to pain. Pain is something that suppresses the body's ability to naturally manufacture melatonin. Therefore, when it is supplemented exogenously, this is something that can help people who have a lot of trouble getting comfortable in bed actually get good quality rest. So, I like to initiate micronized sustained release melatonin at 5 milligrams. I find this works very well. And when we're working up from there, I like to see titration intervals in 5, 10, 20, 50. Personally, I take 200 milligrams of melatonin. You don't need to take that much. I do. Now, when I see my clients and I review how they're going, I would say the majority of them get a great response at 5. And they always come back and they say, this pharmaceutical melatonin is completely different to the stuff that I bought online. It's because it is. So when people are in pain or when they're having trouble sleeping, maybe they've got some PTSD, maybe they've got some sleep disturbances going on in their house, 20 to 100 milligrams is where I see the best results. But it has to be micronized. The other point that is worth noting is that if a patient is on TRT, they're going to have increased androgen levels. This is the point. But DHT in particular actually reduces the ability of melatonin to bind to the receptor, meaning that if you want to have optimal androgen levels, you need to have optimal melatonin levels. And not one single person in this room, young or old, has optimal melatonin levels due to the modern light environment. So, staying on this topic of sleep, I want to talk about a high-performance sleep stack. This is when someone comes to you and they say, what is the health-promoting yet strongest sleep stack that I can use? Basically, they're looking for a healthy version of Ambien, right? So if people want to take a photo of this, I have been working with sleep protocols for a long time. As I said, I've worked with thousands of men all over the world for the last 6 years, and sleep issues are one of the most prevalent problems that people have, which impacts their health, their well-being, their subjective state. Not being able to fall asleep at the end of the day sucks. So I like to combine the following, and what you'll notice on here is there are no botanicals, there is no ashwagandha, there is no lemon balm, there is no valerian. These things work well for some people, but because they are botanicals that work on a number of different systems in the body, they can have inconsistent results. These are essential nutrients. Every human has these as part of their operating system. It's like installing Microsoft Office on a Windows computer. Theanine extended release. You can get this from Life Extension. It's a 400 milligram tablet. I like to see 400 to 800 milligrams. Regular theanine is in and out of the body within 90 minutes. So if you take it at 9 p.m., it is completely gone and ineffective by 12 or 1. Phosphatidylserine. This supplement is one of the most effective things I have seen because it works on sensitizing the cortisol receptors. It resolves cortisol resistance, meaning that your body makes less stress hormone to get the job done, resulting in a relaxing, calming effect that is working on a different pathway and system. Magnesium glycinate, 400 to 800 milligrams, is also extremely effective. Most people are underdoing the magnesium. If you want to push to 800, do not use citrate. I call it magnesium shitrate. It will make you shit. So, sublingual GABA. GABA has poor ability to cross the blood-brain barrier when taken orally, but when taken sublingually, it works very well. There is a brand called Superior Source, which make a very good quality, high bioavailability form of sublingual GABA. CBD, 1/4 milligram to 1/2 milligram per kilogram of body weight. This is something that synergizes very well with the nutrients above, and if needed, if someone needs to go the extra mile with sleep, Nebivolol, 5 milligrams, is a beta blocker. When combined with these other nutrients, works very well to resolve overstimulation of the sympathetic nervous system. This is when you feel jacked up peripherally. And if needed, a microdose of THC, which people need to be very cautious with, especially if they haven't used it before, can be very effective. If you feel the effect of THC, if it makes you feel a little bit like having a laugh and watching The Simpsons and ordering a pizza, you've taken too much. So, if people are hypothyroid, the other thing I like to see is a very small dose of thyroid before bed to prevent potential hypothyroidism and hypoglycemia, which can come as a result of thyroid hormones dipping overnight. So, should everyone take a little bit of thyroid? The same endocrine disrupting chemicals that are messing up our testosterone production in women, they're messing up progesterone production, are also negatively affecting the thyroid's ability to produce thyroid hormone, thyroid receptor binding, as well as conversion of T4 to T3. I see very few people, maybe 1 in 50, with optimal baseline thyroid function, and past the age of 50, I would say 1 in 100. The advantage of thyroid is that you can top it up. You don't have to suppress the body's natural production. Thyroid is also cardioprotective. Thyroid is one of the most effective ways of improving LDL and triglyceride levels in the blood, and for people who have healthy hearts who are wanting to take action to prevent potential development of calcification of the arteries, should be looking at thyroid therapy rather than things like statins or ezetimibe. Empty sella is an overlooked and underdiagnosed cause of low thyroid hormone. If a patient has low TSH and low T3, an MRI of the pituitary is indicated. A lot of the time, pituitary MRIs are only ordered when prolactin is through the roof. This is the important part. T3 increases 5-alpha reductase, increasing DHT. It regulates the aromatase enzyme, meaning that it is part of the body's feedback mechanism for keeping this in balance. It upregulates the androgen receptor. It downregulates the estrogen receptor alpha. It increases dopamine production. It suppresses prolactin, and it increases clearance of cortisol. These are all things that lead to the optimal subjective state that men are looking to achieve from hormone therapy. It is very rare to find TRT patients who don't benefit from at least half a grain to a grain of natural desiccated thyroid a day. These top-up doses can be initiated at 1/4 to 1/2 grain twice a day, or for people who prefer T3 monotherapy, maybe for people who are overweight or who are insulin resistant or who have liver issues, this is something that also works with T3. People can also look at waking temperatures as well. 97.8 to 98.2 can be a useful old school measurement to ensure that someone's thyroid is optimal. So if we're looking at thyroid before bed, low or replacement doses of thyroid in the right context are not stimulating. High doses of thyroid are, low doses are not. Hypothyroid patients will often revert to a hypothyroid state when they use a once daily dosing of thyroid when they get to the early hours of the morning. This causes increased adrenaline production and a drop in blood sugar, leading to a premature cortisol spike. So, patients with severe hypothyroidism or inhibited conversion of T3 to T4 will be hypothyroid in these early hours, and thyroid can be taken with dinner and before bed. It will just have reduced absorbency. This is not the end of the world. You can just compensate for this with a higher dose. So, next one. Adding this in will often drastically improve subjective and objective sleep markers when it is needed. Hashimoto's patients, people with autoimmune thyroid dysfunction, will often benefit from KSM-66 ashwagandha to be added due to improvement in thyroid function as well as GABA-A receptor sensitivity. And Hashimoto's patients also must be optimizing their vitamin D by taking at least 10,000 IU of vitamin D in the morning. So, one more point. Ali's given me the kickoff, but I've got one more point to finish with because this one is key. So, fatty liver disease. This is often deemed as an inconsequential, self-resolving syndrome in the body. It is not. Fatty liver increases in insulin resistance, reduces thyroid function, and it impairs the body's ability to metabolize exogenous testosterone. Fatty liver must be diagnosed via an ultrasound. When there are elevations, either isolated, so AST will be up or ALT will be up on its own, repeated GGT elevations and or elevations in bilirubin. I do not know why so many practitioners are apprehensive towards ordering a liver ultrasound. So, fatty liver is often overlooked with a Gilbert syndrome diagnosis. Gilbert syndrome requires daily glutathione to prevent acne and bloating side effects on TRT. What I am saying here is that if someone has elevated bilirubin without fatty liver, they have Gilbert syndrome. Patients with Gilbert syndrome will have side effects from TRT due to impaired phase 2 liver detoxification without additional glutathione support. Fatty liver can be eliminated. You can flush it out of the body. Number one, no alcohol. Zero alcohol, zero means zero. It doesn't mean less, it means zero. 1 to 1.5 grams of inositol, 1 to 1.5 grams of choline twice a day. And if they're overweight, we need a caloric deficit. This protocol may require a second round of treatment after the ultrasound if the fat is severe. I have only seen this require 2 treatments a handful of times. So I'm going to wrap up very quickly. Just one more thing I want to throw up for you. You can take a photo of this next slide. If there was a supplement protocol, I would recommend for every single male on the face of the earth, regardless of being on TRT or not, this is what it is. Therapeutic doses of the essential vitamins and minerals, a baseline dose of vitamin D that is not a high dose. Eric is going to teach you more about that later today. A therapeutic dose of magnesium glycinate, which is often twice what people are taking, and a therapeutic dose of omega-3 to optimize the omega-3 ratio in the body to increase it above 10%. If additional treatments are needed, ubiquinol is the best thing for heart health. Phosphatidylserine is the best thing for stress. For sleep, micronized melatonin and extended release theanine. And for an antioxidant support, I like glutathione. Keep it simple. Now, I have developed a signature supplement stack with Victory Men's Health if people want one thing wrapped all into one package, but all of those products can be purchased off Amazon, iHerb, wherever you get your supplements. So that is all I have for you today. Thank you for your attention. Many of the side effects that they experience when correcting this are due to the biological consequences of chronic inflammation. It's important to support and adjust the TRT and supplement protocol for the patient in terms of where they're at now based on their different state of health at baseline. Daily injections actually do lead to a natural slight fluctuation in levels because of these pharmacokinetic peaks. So just like caffeine has a half-life of 8 hours, it doesn't have a gradual increase at up to 4 hours and then a gradual decrease in the desired effects.